We're here at the 20th CROI with Jim Curran, who's director of the Center for AIDS Research at Emory. And we very much appreciate your taking the opportunity to visit with us because you are you were a person that visited the virus first, professionally. And at the CDC, I remember seeing the pictures, I guess, somewhere along the line where you were sitting in a room with other gentlemen scratching your head. What the heck? You know? And I guess it came from docs in various cities like New York and San Francisco who were seeing KS. And can you revisit that for just a moment? Because I think that's a great way to begin this discussion.
Fred, it's almost 32 years now since the first cases of pneumocystis pneumonia were reported among gay men from Los Angeles. Shortly thereafter, cases of Kaposi sarcoma, as well as other fatal or life-threatening scavenger or opportunistic infections, were reported in gay men in San Francisco and New York. And that was really the beginning of the AIDS epidemic as we knew it.
And then the beginning, well, that's the reason why the CROI is called the Conference on Retroviruses and Opportunistic Infections, because that was the thing that presented itself. Now it seems like we have comorbidities, which are any number of chronic diseases that are influenced somewhat profoundly, sometimes subtly, by the virus itself, and also the drugs and everything that goes with the virus. We are at a point where you actually did a lot of work since then, but up to which was it, 13th CROI? It was in Denver. You did a presentation at the mark of, was it the 15th anniversary? 25th anniversary of the disease. And that was a profound moment because we really were moving along in the right direction as far as therapy. But now we're moving in a direction as far as hopeful for vaccination, hopeful for maybe a cure, and certainly even more comparable drugs. We now also have hepatitis, which is being addressed more profoundly. So can you catch us up maybe at the point where you, prior to that 25th anniversary, what you felt and how you feel that's different today maybe?
Well, I've had a lot of chance to reflect over the last 32 years about what we know, what we don't know, how far we've come and how far we have to go. On the 25th anniversary, my speech at CROI really dealt with several concepts. One was that prevention was possible, that we should be very hopeful about long-term therapy, and that it could be made available, hopefully, somewhat less expensively and feasibly for people in the developing world. That was really kind of a dream then, though, because it was unclear how much that would be made available. We also had to think that the highest priority for basic science, that of curative therapy, and that of a safe and effective vaccine, were not beyond hope, because we learned in the first 25 years that innovative science can sometimes overcome skepticism. People were very skeptical that we would find the cause of AIDS so fast. In 1983, the virus was isolated. They were skeptical that there would ever be a drug against the virus. When I was a child, my doctor would always say, well, you can treat bacteria, but you can't treat viruses. Or it's just a virus, I hope you live. You know, that type of thing. And of course, antiretroviral therapy has been a scientific miracle and a public health miracle as we now know it. But we have a long ways to go. We still haven't made those huge breakthroughs in the areas of curative therapy or a safe and effective vaccine. And we have a long ways to go to expand our commitment to make what we do know available to everybody. And then finally, we have to battle the old foes, discrimination, scarcity, and denial. Denial, discrimination, and scarcity.
I think the thing that seems to be the biggest challenge is the hope that we will create sufficient inroads into the research that's headed towards the cure, the vaccines, and so forth, that it keeps the interest of the funders, albeit the government, which is now in a state of despair, I guess, in their own right. How do we make those messages resound importantly? Because it seems, I hate to put us against the war machine, which is ongoing and probably necessary, but what is more important than health? In my book, this is the thing that is critical, because not only is it a human thing, humankind thing, humanitarian thing to do, but it's also a fiscal thing. If we allow people to get sick and we can't cure diseases, people are going to be in a rather state of expense to our government.
I think it's good scientifically, and it's good for public health, and it's good politically for the United States to remain leaders in HIV research. It's an epidemic that affects the entire world. We see at meetings like CROI that people have their eyes on the ball. They're focused on the importance of curative therapy. They're focused on the importance of safe and effective vaccines, and they're focused on the importance of showing how to most effectively use the resources we have to save people's lives and prevent transmission to others. The focus is good, and the amount of expertise that's funded by the U.S. government and others is at an all-time high. My greatest fear is that while we have a goal about the end of AIDS, that the goal will remain elusive with premature declaration of victory. And it will be elusive if we don't sustain our commitment to research and our commitment to programs.
And how do we keep that sense of importance and education to those who are making the laws and making the accommodation to spend the money in the government, and maybe business and other contributions? Because, I mean, it's the Clinton Foundation, it's Microsoft, and a number of others that are doing these large donations to the in the right way, but and we also have the challenge with the community. So maybe you could address either or both of those.
Well, it goes back to the denial, discrimination, and scarcity. One of the problems in the United States is that as the death rate has dropped off, the attention of the public, the attention of people, the attention of those potentially at risk is not what it was in the 1980s. Now, I certainly wouldn't trade the mortality rate of the 1980s for the denial that's going on now. But we have to remember that concerns about problems like this demand a renewal of information, a renewal of influence. It's not up to those of us who are aging to tell the people first having sex what the risks are. It's up to the community itself as it goes through to sort of carry the torch itself, and it's a difficult thing to do. You know, each year in the United States, 4 million people have sex for the first time. So if you go 10 years without a lot of attention to AIDS, you've got 40 million people who have sort of awakened during a time of less influence.
We visited before we talk right now, and we had you had mentioned that your daughter is in presenting at the conference, which is very nice. And of course here it is in Atlanta. You can go visit and so forth, see the programs. The thing that I'm concerned about, and we did have on the panel this morning 4 bright young investigators, all looking eagerly at the future, but none of them had seen any of the drama firsthand that you just mentioned, the state of total despair and those days. They don't have that recollection. So the conference puts on this meeting beforehand, the Young Investigators meeting, where they have the Martin Delaney lecture, which is usually a talk about activism, and certainly it's very appropriate as he was an activist savant. But it also covers the basics, and kind of the thing I got out of these young investigators was the ability for them to learn about other fields that were touching on and bearing on the work that they were doing. So that cross-pollination, so to speak. How do you view, or how does your daughter when you visit with your daughter, how does she communicate what she's learning and the excitement about this disease?
Well, my daughter was born 10 days before the first cases were reported to CDC, and I was put on a short 3-month detail to work on it. She's more or less grown up with AIDS, lived at home during the first 15 years when I was at the CDC working on it, and then has left the field briefly in college, but came back and got a master's in public health and worked in India and Tanzania, and now she's in a doctoral program at University of Washington, working in Kenya on her PhD. So she's been a kind of an AIDS person her whole life. when you visit Africa and you visit many places where therapy is simply not available for many people, it does take you back to the pre-HART era in the United States, when you could walk in the Castro district of San Francisco, you could walk in Greenwich Village, and you would see people literally walking by and dying. And you could see the grief that people had, because virtually everybody was with and knew somebody
who was
very dead. That's still true in parts of Africa, and still true in parts of the world. And I think that one of the things that's replenished and renewed the interest of many people who work on AIDS is the global AIDS epidemic.
Yeah, we have an opportunity here, I think, to really, we will be in this program presenting the world health picture and a more full. I know that Kevin DeCock usually covers that with us for sure, profoundly, and he is this year now the chair, as Scott Hammer is the co-chair. So we constantly have this turnover, really well thought of people who are working in the field. And I really appreciate the work that you're doing and have done, and you're currently working in the area of policy, as you say. Is there anything you'd like to mention that might be important for us to make sure that the people in the public and also providers do hear at this point?
Well, I think that the things that I still think about is that we have between 10 and 13,000 people dying of AIDS in the United States each year. That's really unconscionable. With what we know about therapy available, what we know about how much we spend in medical care in the United States, to have people who are many uninsured, many who are afraid to get tested, almost all of whom come in very, very late when it's too late to treat them. It really speaks to the inadequacies in our health system and the gaps in our society to see this happen. There should be very, very, very few people who die of AIDS in our own country. It also bothers me to think that we think that AIDS is over when we have so much discrimination throughout the world, and that discrimination causes people to hide. And when they hide, they don't get tested, that leads to the biggest problem, and that is infected people who don't know they have it transmit it to other people who don't know they have it.
Which is a disease now. It can be very easily,
and it could be treated. It could be prevented. The vast majority of people are good people by human nature, don't want to harm others. If they know they have it and they have care available to themselves, they won't, and the transmission will be decreased. So the tools in our hands are in our hands to greatly diminish HIV. But we have to keep on battling discrimination. Like my friend Ron Baldessari says, it's like weeding a garden.
Yes.
The more you do it, the easier it is, but if you stop, the weeds keep coming back.
Yeah.
And then we have to renew our commitment, both scientifically and to resources for programs to work together to battle HIV.
Thank you very much.
Thanks, Fred.